My talk is restricted to evaluation of thyroid eye disease. The various spectrum of thyroid eye disease. I'm just going to go through a few and discuss what we need to do. This is a typical patient. You can see all the features. It's another patient quite severe, neglected, came very late. Another patient has disease in one eye but not in the other. So what do you do when you see a patient with thyroid eye disease? You want to assess the lids, you want to assess any lag, you want to assess the lag of thalamus, you want to check the ocular movements, you want to see whether there's any Bell's phenomenon or not, and you want to see whether there's proptosis. Again, the instruments are not wonderful recording in proptosis, photographs may be more useful, and you want to check the optic nerve function by doing the usual tests which include visual fields. Soft tissue is very important to assess for activity of the disease, which we'll go through in a bit. You want to look for periorbital edema, you want to look at periorbital erythema, you want to look for conjunctival congestion or injection. Conjunctival chemosis is an important sign, and you want to look at the caruncle and the plica. What other investigations would you like to do? You always do an orthotic assessment for thyroid eye disease. You want to look at binocular single vision, which I'm sure Dr. Ramesh Murthy will talk a bit about. And all our patients, when they are referred for thyroid eye disease management, will always get a visual field test. And not all patients need a CT or MRI scan. In mild disease, we wouldn't do that unless we are taking decisions regarding treatment, especially towards surgery, or if there's any doubt in the diagnosis, would you order investigations like a scan. It's another patient with ocular movement abnormality with thyroid eye disease, and this is quite neglected thyroid eye disease. They can affect optic nerve head, as you know. Choroidal folds are an important sign when the orbits are really tight. You need to look for that. All the patients sent for thyroid eye disease will have a dilated fundus examination and photographs done if there are any signs. And when you do CT, when you do MR, we'll talk a little bit about it, and you can see all the typical features of thyroid-related eye disease with significant enlargement of the extraocular muscles. And grading is a big bugbear. There is no single grading system which is going to help you in assessing a patient, but the simple one and the historic one, and especially if you see examiners like me or slightly older, may still talk about no specs, but that's completely gone. And if you're going for a younger examiner, then you don't want to talk about no specs. There is a Gorman system, there is Moritz, which is quite popular in continental Europe, and there's Bartley in America, then the Visa system, which originated from Vancouver in Canada by Goodman, and then there are simpler versions which we tend to use. And there's no grading really helps in the individual patient. It may help you in the follow-up, but not in the individual patient. Why is it important to know about the grade? Thyroid eye disease is a self-limiting disease in the majority of patients, but what they leave behind is what you're worried about. So the disease activity goes up and then drops down. There are various trigger factors for the disease activity which we'll talk about, but while the disease is active, if you treat it adequately, you can avoid the lengthening of this curve and maybe reduce it quickly. So the activity itself goes up and down and can settle spontaneously, but what it leaves behind is what you're going to be dealing with. And while it's active, you can take action both medically and surgically to reduce the risk of long-term problems. And most specs, most of the juniors will know here, it's all available in the textbooks. I don't want to bother you, we don't use it full stop. And useful for exams if there's an older examiner. Clinical activity score is useful to know. It's majority used in the continent of Europe. We don't tend to follow it, but it's a useful scoring system. It's again available on the net. You don't need to make a note of this. CAS, done by Moritz from, he was in Amsterdam and not there. He moved his workplace. And each one is given a score of 1 and the maximum is 10 points. So at each clinic visit you can say 2 out of 10, 3 out of 10, 6 out of 10. That gives you a rough idea whether the disease is getting it worse or better. Then the Visa system, which is popular in Canada, vision, inflammation, strabismus and appearance. So each one have a page to fill in. If you have the time to spend half an hour with each of your patients, it's a fantastic system to use. And each one has a page to fill in, and again gives a score for each. And you can score the patient every time they come, and then take it from there and see whether the disease is getting worse or better. And there are other determinants. Okay. If your endocrinologist comes up to you and says that this patient has hyperthyroidism, there is some eye disease which you have been managing, unfortunately we are not able to control the hyperthyroidism, do you want us to continue and increase the dose of anti-thyroid drugs, or do you want us to give radioiodine, or do you want us to suggest surgery? But the evidence suggests that radioiodine and surgical excision of thyroid gland increases the risk of progression of the eye disease. So it's important to advise, if possible, to control the hyperthyroidism by oral anti-thyroid drugs rather than suggesting radioiodine or surgical excision. And as discussed already, smoking definitely increases the severity. For any autoimmune disease like thyroid eye disease and thyroid disease in general, there are trigger factors that we concentrate a lot in the last 5 years than before. So if you can control the trigger factors, you can control the thyroid eye disease. So when you see a patient, you need to find out what is likely to be the trigger factor in that individual patient. So when you evaluate, the commonest trigger factor is changes in the thyroid function. The commonest form of thyroid eye disease is patients, female patients who have been hyperthyroid for about 18 months. That's the commonest. But thyroid eye disease can happen among the ones who don't deal with much thyroid, can happen in euthyroid patients, hypothyroid patients, hyperthyroid patients. So just because they do not have a biochemical abnormality in the blood test doesn't mean they do not have thyroid eye disease. But if you can control the thyroid functions quite closely with your endocrinologist, that alone may be enough to control the disease activity. So if a patient comes with significant eye disease, and the thyroid functions are not under control, you work with your endocrinologist, get the thyroid functions under good control, that alone may be enough to treat the eye disease. As discussed, smoking in our practice in the UK is a common association with eye disease. So we try to suggest to the patient to quit smoking or send them to quit smoking service. As I mentioned, radioiodine increases the risk of activity. And any ongoing illness can be a trigger factor for that individual patient. A chest infection, urinary infections, tooth problems, all that can continue to be a trigger factor for the eye disease. And do not forget, more and more in the last few years, we are recognizing some severe personal changes like job loss, bereavement, divorce, etc. can act as a trigger factor in the eye disease. Certain things are controllable and certain things are not. So if you can control some of the trigger factors which are controllable, fantastic. You don't need to subject the patient to more significant treatment regimes like medical treatment regime which has gross side effects, or any surgery for that matter carries risks. Don't forget other associations. It is an autoimmune disease, can be associated with other autoimmune diseases. Obviously, diabetes in our population here especially is a problem management. What we tend to do is use a simple system called mild, moderate, and severe, active or inactive. Is it progressive or non-progressive? So when somebody presents you regarding a thyroid eye disease, what you want to know, is it mild, is it moderate, is it severe, is it active, is it inactive, is it progressive or non-progressive? These are all the questions you need to ask, and most of the answers can be easily be given instead of going through a long scoring system. Mild, there is some irritation and soreness, mild retraction, very little congestion. Moderate, in addition to all that congestion around the extraocular muscle insertion, some restriction of eye movements, some edema in the lid and conjunctiva. Severe, I don't need to mention, when there is optic nerve compression, when there is corneal exposure signs, and very severe proptosis. But again, if you look at this patient, the optic nerve can be of different sizes, okay? Some patients are born with a short optic nerve, so even when they have small amount of proptosis, they can have optic nerve stretch and optic nerve compression signs. So do not go by amount of proptosis at all for the severity of the disease. And we have a grouping UGO in Europe, which again has a grading system if you are interested. Again, takes a long time in our busy practice. We have about 900 thyroid eye disease patients whom we manage, so it's impossible for us to fill in such forms. But you can go to the website, download the form and use it. But it's very educative for other reasons. There is another grouping called iTest, which I'm a member of. That again has a website which you can visit, and again gives a scoring system. As we discussed, should we do a CT, should we do an MR? It's a debate which we can carry on for ages. There is no easy answer. Does stir sequence MRI scan, does it give you whether the disease is active or not? There is some papers to suggest it is, but practically it doesn't. So MRI scan doesn't give you anything extra to a CT scan. In our practice, we prefer CT. If you are planning a surgery for the patient for decompression, you definitely need bony views. If you're not planning surgery and you're worried there is some other soft tissue abnormality in the orbit and not thyroid, then I would go for an MRI scan. This patient has severe proptosis, as you can see, but she has severe myasthenia as well, no ocular movements, severe proptosis with totally straightened optic nerve. No Bell's phenomenon, no lid movement, nothing, burnt out myasthenia. She underwent bilateral decompression with a small tarsorrhaphy laterally. Anybody looking at this patient would never imagine thyroid eye disease. So if you look at this patient, you will not score anything for thyroid eye disease. But this patient has severe thyroid eye disease, no proptosis. You can see the visual field defect. And you can see enlarged medial rectus just on the left, compressing the optic nerve. Again, goes to show the scoring system in this patient. You would have never picked up any problems other than the optic nerve compression, which you might have thought was some other reason rather than thyroid. Again, goes to tell you that the grading systems are not as useful for the individual patient. Each patient is different. You need to assess the patient and decide what you want to do. So this patient, because she did not have any active disease, there is no point giving her any immunosuppressive drugs. So she underwent a small posterior decompression and did brilliantly well. So this patient came to us with what looks like moderate active thyroid disease. We treated her with IV prednisolone. What we missed was the blink reflex. She didn't have much of proptosis. She just had congestion. Her blink reflex was not great. Unfortunately, in spite of us treating her quite aggressively medically, we did not pick up the absence of blink reflex. She developed a corneal abscess, and we ended up doing a tarsorrhaphy, which is accepted defeat for an oculoplastic surgeon. Though she didn't have much proptosis, she had a tight orbit, so we did a small decompression, medial and lateral, did a small tarsorrhaphy on that side, and you can see the eye is quiet and there is no problem. So again, while assessing, think of the blink reflex. It's another patient with gross proptosis. There's no point this patient is going to be treated medically. So not only she needed decompression with advancement of the lateral wall way forward. You can see where the globe is compared to the orbit. So you can advance the lateral wall, which I'm sure Ganga will talk later. Again, this patient you would call it moderate, maybe not severe. No proptosis or very little proptosis. Just congestion out there. You can see the significant visual field defect. Especially older men over the age of 50, when they present with thyroid eye disease, they usually have severe disease and they usually need more intervention from our point of view. This is a patient you would say has moderate active thyroid eye disease, not much of proptosis, so she can be treated medically with IV prednisolone to start off with. This patient has a corneal abscess by the time he came to us with thyroid eye disease. In conclusion, evaluation and management is still very controversial. Early intervention, especially immunosuppression, does involve evaluation of the activity. Standardized evaluation hopefully will be developed. We are still waiting. Thank you.